Welcome to the OMIC course modules on patient safety. This first module focuses on human error and the quality improvement process. We would like to thank the American Board of Ophthalmology for their assistance in developing these modules by allowing us to incorporate portions of an extensive ABO course on patient safety that was created in 2014 but is no longer in use. There are two sentinel principles in maximizing patient safety in medical practice. First is that humans are prone to error, and systems and processes that don't account for this will eventually fail. As Deming notes, rather than relying on perfect performance, the way to deal with the problem of human error is to design systems and processes that have redundancy and checkpoints in order to prevent human error from producing a bad result. The second principle is that open and honest communication is paramount in promoting a culture of safety. This includes discussion of errors among the medical team and disclosure of adverse events to patients and families. Ignoring or covering up errors is never acceptable. The Institute of Medicine's 1999 publication, To Err is Human, defines an error as the failure of a planned action to be completed as intended, this is an error of execution, or the use of a wrong plan to achieve an aim, this is an error of planning. An adverse event, on the other hand, is when there's patient harm caused by medical management of the patient and not by their underlying medical condition. When an adverse event results from human error, it's termed a preventable adverse event. This diagram shows the overlap between errors and adverse events. An example of a simple error might be prescribing a patient the wrong dose of a drug, say 500 instead of 650 milligrams of acetaminophen, and this does not result in any patient harm. An example of an adverse event is the use of neomycin ointment in a patient with no known medical allergies who then develops eyelid edema after the first use of the drug. But if a patient with a well-known history of neomycin allergy receives a drug through human error, this would be a preventable adverse event. And if a patient with a history of neomycin allergy is prescribed the drug, but the nurse or pharmacist notes the allergy and prevents it from being administered, this is a near miss. Near misses are also referred to as close calls or good catches. From a quality improvement standpoint, near misses should be treated with the same level of concern as a preventable adverse event. The Institute of Medicine attributes most patient injuries not to blameworthy clinicians, but rather to systemic factors such as unrealistic reliance on human memory, poor communication systems, unrealistic demands on human vigilance, too little respect for the consequences of fatigue, or reliance on handwriting in the computer age, and so on. The fact that near misses and preventable adverse events occur has been a driving force in the quality improvement movement in medical practice. Some examples of pertinent and useful QI projects in ophthalmology include projects to prescribe polycarbonate lenses for monocular patients, make sure that patients with diabetes have a PCP, improving patient experience by decreasing the on-call response time and decreasing patient wait times. All of these things would be expected to result in either better patient outcomes or a better patient experience of care, or both. Walter Schubert from the Bell Laboratories developed the PDSA cycle, which is an integrated learning improvement model. It starts with a plan regarding some process or an outcome or a service. An example of a process variable may be how many new glaucoma patients receive gonioscopy. An outcome measure would be the amount of improvement in visual acuity after cataract surgery. In the planning stage, we gather data on the current landscape, look for existing benchmarks, decide whether to pursue a project, and if so, think about what specific steps we could change or add or delete in order to demonstrate improvement. After we design the change, the do portion requires us to implement that change for a certain period of time or with a certain number of patients. After that's done, the study phase requires us to analyze the data to determine if we have made a difference and whether changes could result in even more improvement. Then we move on to act, which may include incorporating the change we studied long term, doing another study with a different change, or deciding that what we achieved is what we wanted and now we can move on to study something else. CQI, or continuous quality improvement, is also referred to as total quality management. An absolute necessity for quality improvement is the ability to measure what we're studying, for without that measurement, we have no idea whether we're making a positive difference or not. To be successful in QI, physicians and non-physician leaders in a practice must buy in and set the tone, because it often requires a change in culture. The focus should not be on people's errors, unless they're malicious or willfully doing wrong, or unless they have gross negligence. But the focus should generally be on designing processes that prevent failure and prevent patient harm. Rather than singling out individuals, the focus is on working as a team to achieve positive goals together for the good of our patients. And remember, we always have to keep measuring, otherwise we don't know if we're making a difference. So the summary of quality improvement is to focus on the process and making that better rather than singling out and punishing people. Use the PDSA cycle to decide on and measure what you want to improve and see if the changes you make actually work and if they should be implemented beyond the study period. I'd like to share with you an example of a QI project we did in our practice, which was to improve the number of patients who were prescribed impact-resistant lenses when they were functionally monocular. The AAO preferred practice pattern guidelines for amblyopia define functionally monocular vision as less than 20/40 in the worst eye, and they recommend the use of protective eyewear at all times for people with monocular visual impairment. This project consisted of looking at qualifying patients with an outcome measure of how many got a prescription for impact-resistant lenses within the 90 days of presentation. So first we needed to know where we were starting from. Although a lot of our doctors thought we were doing pretty well, none of us really had any idea. So we looked at a year's worth of data and eventually did multiple interventions to improve the outcome measure. To start with, we evaluated a cohort of new patients who were functionally monocular seen over a 1-year period of time. To our disappointment, fewer than half of these patients received a prescription for protective eyewear. A survey to understand why patients were not prescribed lenses found that the most common reason was that doctors either forgot or they typically didn't prescribe glasses at all. Others were concerned that polycarbonate lenses would be unacceptable to the patient due to their cost or their optical properties. The first intervention we tried was putting a pop-up window in the EHR for patients who met criteria for functionally monocular to remind them to prescribe polycarbonate lenses. We also added a tab under the plan section that was shaded in red and reminded again of the necessity of impact-resistant lenses for functionally monocular patients. And we had a clever sticker that we put on the side of the monitor screen for all computers in the lanes as another reminder. And this turned out to be somewhat successful, increasing compliance from under 50% to 56% over a 5-month observation period. But we still wanted to do better, so we undertook a second intervention. Initially, we wanted to default all prescriptions to impact-resistant lenses that the providers could uncheck if they wanted, but some doctors didn't like the idea at all. So we asked for volunteers for each group, and we got 17 doctors to agree to the default, whereas 11 did not participate. After a little over a month, this showed a dramatic difference in compliance between groups, with nearly 2.5 times more patients getting prescriptions for impact-resistant lenses in the default group. And there was also a small increase from the first intervention as well, up to 62.5%. At this point, we decided to default all prescriptions to polycarbonate, again preserving the ability for providers to uncheck this at their discretion. After the universal default was employed, we found out that 69% of functionally monocular patients got a prescription for safety glasses. Of the remaining 31%, either they weren't refracted or given glasses at all. So every patient who was functionally monocular that got a prescription had a prescription for impact-resistant lenses. So while this did not result in perfection, every intervention in our QI project produced an improvement from the one before, and overall we had just over a 50% increase in compliance. In summary, the basic message of quality improvement is that all people are going to fail, and we can never expect or achieve personal perfection. We can, however, mitigate against these failures by changing and improving our systems through reminders, double checks, and hard stops for review. Quality improvement is and should be a continuous process. We pick a problem area to measure, make changes, remeasure, and make more changes until we're satisfied. And we keep then the process continuous by moving on to another problem. It doesn't have to be complex or burdensome, and it becomes enjoyable and rewarding as we achieve improvement in our outcomes. Thank you for participating in Part 1 of the Patient Safety course. Part 2 of the Patient Safety course focuses on communication and teamwork, as well as how to review processes when we are faced with undesirable outcomes. Only a small percentage of medical errors are caused by physician lack of knowledge. Rather, errors in communication are by far the greatest cause of medical error. There are many techniques to optimize communication in medicine. As physicians, we should model good interpersonal skills with others and also have standard ways that we communicate about patients. Whatever styles we adopt, we should use them consistently in order to make sure we both transmit and receive the information we need regarding best patient care. The transfer of patient care from one provider to another is the most common type of medical communication resulting in patient harm. Again, standardization is very important. We also have to remember that the people we're talking to may not have the same level of understanding of the patient or the diagnosis and plan that we do, and we cannot take their level or experience of knowledge for granted. This is particularly important if we're talking to an ophthalmologist who is not in our specialty, to a non-ophthalmologist physician, or to a non-physician colleague. Again, standard handoff techniques are important, and verbal communication is always the gold standard, because texts or emails may not go through, people may not read them in a timely fashion, and we may write abbreviations that may be incorrect, like OD instead of OS, or IOP of 35 instead of 53, etc. On the other hand, the ability to transmit photos or copies of exams or tests or documented plans electronically is a big plus and should be incorporated. The SBAR technique is recommended by many professionals and different organizations for patient handoffs. S stands for summary, which is a review of the current situation. B for the background, the pertinent details, pertinent positives and pertinent negatives for the patient. A is assessment, the assessment of the person initiating the handoff, and R for their recommendation to the recipient of the handoff on what they should do and how urgent this appears. SBAR has been demonstrated in many papers to improve handoff communication and decrease patient adverse event. Next, we will discuss teamwork. For many decades, medicine was practiced from an individual physician perspective, but we now recognize that it is best played as a team sport. Moving from an individual to a team perspective helps with communication, provides redundancy, and results in fewer errors. It also helps balance workload and prevents errors from burnout. Working in teams is common in residency and fellowship training, but sometimes gets lost in real-world practice. It's important for us to maintain a team approach with our practice partners, our colleagues in the community, and our non-physician personnel, including those who are not directly involved in patient care, for example, schedulers, people in your business office. This slide lists the top 5 reasons medical errors occur. As we discussed earlier, communication is an important component. The number 1 reason errors occur is that some type of communication interruption happens before a crucial task could be started or completed. When that happens, remember, we can answer a phone call or text later or tell someone you're speaking to that they have to wait for a minute. We've all have heard of cases where a general surgeon takes a phone call near the end of the case and inadvertently leaves an instrument in the belly. So we need to avoid these interruptions. The second reason errors occur is insufficient staff for the workload involved. Now, the insufficiency may be in the number of staff, but it also may be in the level of knowledge or experience of the staff. So this brings communication to the forefront again, as we have to sufficiently educate and train our staff and communicate with them to make sure they understand what they should and give them the opportunity to ask questions of us. I know of a case where a technician did not realize that patients had to have their contact lenses taken out before IOL calculations, and this resulted in a wrong IOL insertion in that patient. The last two things here have in common the problem of going too fast and skipping steps in a process or procedure. While the economic and access problems in medicine may tempt us to speed up, following standard protocols and not skipping steps or being incomplete is crucial. For example, many of us in pediatric ophthalmology encounter failures to diagnose refractive accommodative esotropia because patients are examined 10 minutes after drops are instilled and they may show a hyperopia of only 1.5 diopters, when after 30 minutes of dilation and cycloplegia, it's +4. As discussed briefly in Part 1, a sentinel event is an adverse event that results in a notable harm to the patient, like wrong eye or wrong IOL surgery. A sentinel event should never happen. A near miss, also called a good catch, is an error that's caught before it's made, preventing patient harm. From a safety standpoint, however, both of these should be treated with the same sense of urgency and should result in a similar action. This could be as simple as adding a second check in a process, but when the events are very serious, a more formal review of how the error occurred needs to be initiated with a team of people. There are many names for these teams, but they should all comprise a variety of people. Certainly, people involved in the incident and in direct patient care are important, but it's also important to get the perspective of people who had nothing to do with this particular event or may not even take care of patients. A variety of people with different levels of education and experience will help to yield a response that will be both effective as well as practical to implement. It's crucial that everyone on the team is treated with the same level of respect and has the same ability to speak up and share their ideas and thoughts. An RCA, or root cause analysis, is a backwards look at how a sentinel event happened. Things that should never occur, like wrong eye enucleation, missing an MRI report of a brain tumor, intraoperative death, all things like that should prompt a root cause analysis. The team is charged with getting all the details of the event, constructing a clear timeline of events, looking for errors, and identifying ways to prevent errors like that in the future. And just because you find one obvious cause for an error doesn't mean there are not more. Every step needs to be looked at equally. And just like in any safety team, we want people from a broad variety of backgrounds, including people not directly involved in patient care, as well as people who are not involved in this event. Common etiologies of medical errors after a root cause analysis include equipment that malfunctions, a culture where someone notices a problem that may be occurring but they're afraid to speak up, a poorly educated team where people aren't sure what they're supposed to do, and there are always going to be areas that play a role that we can't control, like how sick a patient may be, how impaired an eye is, whether there's a storm or some other natural process causing power loss, whether there's a sudden illness in a surgeon or a medical provider. An FMEA, or failure modes and effect analysis, is sort of a proactive root cause analysis. Whereas a root cause analysis evaluates potential causes after a sentinel event occurs, an FMEA looks for ways to prevent a sentinel event before it happens. An FMA find out that after evaluating a protocol for technicians to perform IOL calculations, there's no instruction for the techs to ask the patient whether they have their contacts in or not. And this FMEA could result in a revised work protocol to include this question that's standardly asked and prevent an error from happening. Or they may see that the placement of allergies on the EHR screen is not in an easy place to see and may recommend a change in this to prevent an untoward event. An FMEA would think of a sentinel event that has not yet happened, like a wrong IOL, but could, and look at processes in place to see what could be changed to produce an even better protection against an adverse outcome. But when a sentinel event does occur, we need to have a rapid response safety team ready to investigate and perform an RCA. Every practice should be able to recognize sentinel events that should never happen and thoroughly analyze it shortly afterwards. Obviously, post-op endophthalmitis or patient death, wrong IOL, these are sentinel events, but there are others, such as a patient with obvious giant cell arteritis that doesn't get steroids in a timely fashion, or the delayed diagnosis of glaucoma because a patient being seen for another problem goes for a long period of time without an IOP check. I'd like to review with you an RCA done in our practice after a patient was prescribed a wrong dose of atropine that resulted in additional treatment. The patient was a 7-year-old girl referred for myopia management. She had a history of esotropia for which she had undergone 2 prior strabismus surgeries, but was otherwise doing very well. You can see from her refractive progression that she could be a candidate for treatment to retard myopic progression. When she progressed by a diopter over 6 months, use of dilute atropine was discussed with the family, but they decided to wait at that time. When she progressed again after 6 more months, they decided to go ahead with the drops, and 0.01% atropine was prescribed by the physician. However, the staff member sending in the prescription checked 1% atropine, which the patient received for 2 weeks and then came back for blurred vision. She also had a new esotropia at near that was not present before, which was due to the increased accommodative effort after her prolonged cycloplegia. At the time, this error was recognized and the appropriate dose was prescribed, but an RCA was initiated. So the patient returned on the correct dose of drug, but after a few weeks still had crossing at near that now required a bifocal. And to come to the end of the story, the patient eventually required another strabismus surgery to get out of the bifocal and wear contacts. It's very likely that this surgery would never have been necessary if she had received the correct dose of atropine. So in the RCA, we found out that there were potentially 3 points of error that could be addressed to prevent this problem. First, there was no standard overview of prescriptions and no routine review and sign-off by attending physicians. Second, the electronic prescribing system used did not communicate directly with our EHR. And the compounding pharmacy we sent the drops to did not take e-prescription. Finally, what was written as 0.01 was misread as 1, but there was no corresponding text to indicate that the dose was to be diluted and had to be made at a compounding pharmacy, which could have prevented the error as well. So since 3 different potential causes were identified, we wanted to address them all in the RCA. To address standardization, doctors had to physically sign off on any new prescription that was entered by someone else other than them. Subsequently, we've converted to another EHR where this is standard procedure in that system. We also initiated talks to integrate the electronic prescribing system with our EHR, and in the end, when we transitioned to Epic, this solved that problem as well. Regarding the documentation deficiency, we created a macro for compounding pharmacies when these prescriptions had to be sent. The large number of prescriptions written every day makes it helpful when staff enter some, but ultimately the prescriber is responsible that the correct order is carried out. Instituting mandatory provider review before the prescription would go through was an example of creating a hard stop and a recheck in the system, and it wasn't burdensome to doctors. If it was correct, 1 click was all that was necessary, but if not, it could be rewritten and a medical error would be avoided. In summary, communication is the medical competency most likely to result in medical error. It is not medical knowledge, patient care, procedural skills, or system-based practice or professionalism that is a typical cause of medical error. It's a fault or a failure of communication. Effective and efficient communication in medicine is a learned skill, and should develop with some degree of standardization that starts with the doctor and permeates throughout the entire healthcare team. These steps to improve communication will result in improved patient safety. But since people are fallible, errors will occur, and systems must be designed to create ways to discover potential errors. When errors do occur, specifically sentinel events or things that should never happen, a careful drill down by a safety team comprised of those involved as well as those not involved and those with and without direct patient care is necessary to analyze this sequence of events and prevent future similar errors. Part 3 of the patient safety course will focus on disclosure when adverse events occur, as well as characteristics of a culture of safety in our practices. Just as errors will occur, so will adverse events due to medical error. It's a crucial but a difficult role that the physician must play in disclosing these events to patients and their families. Disclosure is the process of providing data in an understandable fashion about what happened during an adverse event in a manner that's open and honest. When the adverse event is due to medical error, apology is also appropriate. Apologies should convey several components known as the 4 R's. First is the recognition that an event happened and the conveyance that the adverse event was in fact due to a medical error. Next is the acknowledgement that even though the error was unintended, some person or group of people hold responsibility, and there will be work to figure out exactly what happened and make sure it doesn't happen again. The third R is a sincere expression of regret that it happened. Those who are a victim of a medical error at some point will also consider the issue of reparation. This does not necessarily mean financial gain from a lawsuit, but assurance that changes will occur to make sure a similar event doesn't happen again, and assurance that the physician will continue to be involved in the patient's care throughout the entire process, that the patient will be not abandoned, and the physician and his team will strive to repair the damage and restore function to the highest degree possible. Regardless of where the source of medical error lies, the physician is solely responsible for this disclosure to the patient and the family. Other members of the care team may contribute in the disclosure and the apology if necessary, but the communication strategy should be directed by the physician. Obviously, at some point in the process, the physician may want to consider their risk management representative, and the timing of this will be different for every case. Regardless of the timing, however, the physician bears the responsibility to initiate and complete the disclosure process. It's often helpful to think of things from the patient's point of view. Patients want, and have the right, to receive a full disclosure of events, including the hows and whys and the details of exactly what happened. Obviously, all the details are often not known at the time of initial disclosure, so this is a process that may occur over a period of time as more information becomes known, including completion of an RCA if the adverse event is a sentinel event. The rights and responsibilities of the physician include disclosing adverse events, but also reporting it to systems, whether it be their practice partners in management, a hospital, or ASC, and also participating in a process to understand what happened and what needs to be changed to prevent a similar occurrence in the future. Disclosure of adverse events is a difficult thing, especially for physicians who generally are very high achievers and carry a strong track record of success. In addition, there's fear of being sued, there's lack of experience with difficult conversations, and of course everyone has a personal ego that gets in the way. Many doctors are still used to thinking about the practice of medicine from an individual rather than a team perspective. But it's only from the team perspective that we can have the greatest success in analyzing and preventing medical errors. The culture of medicine, though changing, is still often a very hierarchical one, with the doctor being the captain of the ship and others behaving in a subservient or very secondary role. Other team members may also need to be educated in systems-based thinking, so they should not be afraid of retaliation in reporting or discussing or questioning about a potential medical error. In summary, the physician must initiate the disclosure process. It's our responsibility to be sure we are completely honest in a language that a layperson can understand. Disclosure may need to be repeated multiple times as new information becomes available and until patients and families express their full understanding. And disclosure should never be about scapegoating other people or disparaging ourselves, but should focus on the fact that there are generally several errors in the system of care that allowed this to happen. Apologies are appropriate when an adverse event is clearly due to medical error. Remember the 4 R's in an apology. It's also important to understand that there is no evidence in the medical literature or the OMIC experience that apologies make a lawsuit more likely. In fact, a sincere and appropriate apology is more likely to actually prevent legal action. Apologies should always express sympathy, which is the recognition and understanding of the complex emotions that patients and families go through during a sense of loss. Empathy may also be appropriate in some circumstances. For example, if you or a loved one have experienced something similar, or if you have a very close relationship to the patient. But the important thing is it should only be expressed if truly sincere. Insincere expression of empathy or sympathy is easily recognized, and they delay the emotional healing process. A good disclosure with appropriate apology and sympathy promotes healing for the patient and the family. It rebuilds and strengthens trust between the patient and doctor, and allows both the patient and the doctor to begin to recover from the emotional trauma of an adverse event due to medical error. It may seem like an overwhelming amount of work to be involved in QI, perform a root cause analysis, or make appropriate disclosures of medical errors. But all of these can be supported by a surrounding culture of safety in our practices. There are 3 types of medical cultures. In a punitive culture, often what's occurred through the decades, everyone lives in fear of reporting a mistake, and so you can never truly evaluate our processes and systems to get better. The converse is a blame-free culture where no one is held to a standard and laziness triumphs over a sense of responsibility or desire for excellence. The just culture holds both individual members as well as the team responsible for continuous improvement. It also only incorporates team members who themselves have a strong desire to be both individually and corporately responsible. Key features of a just culture, or a culture of safety, include recognition that we work in a high-stress, high-risk profession, and a strong desire to produce continually better and safer operations. Everyone on the patient care team has both the responsibility and the right to speak up whenever they are concerned about a potential error or safety issue, and everyone is committed to address these issues ad infinitum. As an example, in our system, we recently updated and standardized our timeout processes. One of the issues we faced was making sure that the non-physician members of the team felt empowered to speak up with any concerns. Through this process, we have captured several near misses and have been able to make process changes going forward. But it would not have happened without the participation of these people. We benefit not only with better patient safety, but also less medical legal exposure. One thing about ophthalmology is a lot of what we do day in and day out is really successful, which makes it crucial for us to pay strong attention to outliers from the norm. When you do hundreds of successful procedures every year, it's even more important to really pay attention to sentinel events when they occur and do a full disclosure as well as a full RCA or similar analysis. And to reiterate, a near miss, which is actually a good catch, must be treated with the same degree of urgency as a sentinel event. In fact, as you proceed with a greater emphasis on patient safety, you'll see more and more good catches. Don't interpret this as a negative. It's really a positive because it means these were things that were not being recognized or reported before, and now they are, and they're presenting new opportunities for practice improvement. Just as in disclosure, physicians also have the responsibility to lead in the formation of a just culture. Without our buy-in, this process is impossible. We need to promote things like quality improvement, safety teams, disclosure, And we should be the first to applaud a nurse or technician who voices any concern about a potential patient safety issue. We also have to be the ones to infuse energy when the process stalls. It's truly a never-ending journey. In summary, physicians have the responsibility of initiating and ensuring completion of disclosure of adverse events due to medical error, as well as promoting a just culture of safety in our practices. Disclosure, empathy, and apology help both patients and physicians heal after adverse events, and they do not increase medical legal risk. As we move from an individual, hierarchical system to one that focuses more on patient care teams and places quality and safety foremost, we will be caring for our patients and also receiving the best care ourselves when we are patients in the best way possible. We hope that this patient safety course has been useful to you. Please scan this QR code and complete that attendance form in order to receive your premium discount.